COPD is characterized by a chronic inflammatory response throughout the airways which causes limited airflow due to inflammation. When dealing with a patient who may have COPD, it is important to get as much information as possible about themselves to see if there are any signs that could be contributing to COPD. Asking about their current or past habits, such as if they are a smoker or have smoked in the past, how their diet is and if they're getting appropriate nutrition, and their living and working environment to see if they have any exposure to harmful pollutants such as chemicals or dust. You can also get them to talk about past history such as any recurrent lung infections or if they have any family members suffering from lung diseases such as COPD. Subjective questions are going to get the patient to talk about how he or she is feeling and their own opinion. By asking subjective questions, the goal is to get the patient to talk specifically about how they are doing and how they feel. Many COPD patients suffer from chronic cough, so asking questions like, how often do you cough? How long have you been coughing? Is it getting worse? And even asking about whether they cough up any mucus. Feeling of fatigue and trouble with physical activities may be due to COPD, due to increased levels of CO2, so asking questions like, how often do you feel fatigue or experience weakness? Or describe your level of fatigue right now, could provide some signs of existing COPD and lead to early diagnosis. COPD patients are often short of breath quite a bit, even after minimal activity such as going up a flight of stairs or walking to the washroom and back. So some more appropriate questions to ask would be about how often do you experience shortness of breath, and asking them to rate their level of shortness of breath on a scale, and when they experience shortness of breath the most. The first thing you're going to do when seeing a patient with COPD is looking at their general appearance and inspecting for any signs or symptoms. Some obvious signs and symptoms to look out for is any nicotine staining, cyanosis in the mucous membrane or fingertips, which depict low oxygen level, and edema in the legs or abdomen. Looking at how the patient breathes is key because if they're taking frequent rapid breaths and possibly hyperventilating, this could mean that they're in respiratory distress and having difficulty breathing. They may also be breathing with pursed lips or in a tripod position in an attempt to obtain more oxygen. Normal or quiet breathing is accomplished just by the use of diaphragm and external intercostal muscles, but if you notice they are using their accessory muscles to breathe, it shows they are forcing expiration, which involves the internal intercostal and abdominal muscles. Lung enlargement will cause the diaphragm to flatten and is why the person will use their accessory muscles to try and get air out. This, however, leads to a barrel chest. Therefore, another parameter that can be inspected is the chest anterior-posterior diameter. When palpating a person who may have COPD, there are many things to be considering. You can start with palpating the radial pulse, and a bounding or abnormally strong pulse can be a sign of carbon dioxide retention. Palpate the chest wall to assess for any obvious points of tenderness, masses, or rib deformities. Also, palpating the lateral borders of the trachea with the sternal notch helps in determining if the trachea is in normal midline position or if it's deviated, as a deviated trachea can indicate lung pathology. Other major areas of palpation include all of the head, neck, and axillary lymph nodes. An abnormal number or size of lymph nodes can indicate a respiratory tract infection, which could be associated with COPD. Percussion will help identify whether the patient's lungs are hyperinflated with air. In COPD patients, the percussion sound is hyperresonant, which is louder and hollower than normal. This is caused by hyperinflation and a sign of increased air inside the thoracic cavity. Patients with COPD often present diminished and distant breath sounds caused by barrel chest, hyperinflation, and air trapping. They also experience prolonged expiratory time and unequal breath sounds. During oscillation of a COPD patient, you may hear crackles and wheezes. Crackles are due to airway secretions and disappear in coughing. Wheezes are produced by the vibration of the narrowed walls of airways, which indicates inflammation and resistance in the airway. Intravenous therapy is treatment that infuses intravenous solutions, medications, blood, or blood products directly into a vein. They are categorized according to their relative tonicity in relation to plasma. An isotonic solution means it has the same Osmolality as blood plasma, which means solutions are removed from the plasma to the tissues until equilibrium is reached. Used during fluid volume deficient, loss of GI fluids, plasma, or hemorrhage. Hypertonic solutions means the osmolality is greater than the plasma. The fluid shifts out of the cell into vessels, which increases vascular volume and decreases the cell water. This can be used when patient has edema, or it can be a temporary treatment for shock. Hypotonic means the osmolality is less than that of the plasma. Water is pulled out of the vessels and into cells, which causes cells to swell and provides free water for cells and for excretion. And this is used to reverse dehydration and used for hypernatremia. Patient and IV site assessments should be done on a regular basis. Assess both the IV insertion site and the dressing on IV sites, looking for signs and symptoms of phlebitis or infection. You should check for fluid leaking, redness, pain, tenderness, and swelling. Immediate and vigilant monitoring is important because there is no going back once administered. You need to monitor for reactions to the medications as well. It is important to keep monitoring patients for adverse effects that may appear during treatment. Also, it is important to follow agency policy in relation to site maintenance and flushing. If the patient is on continuous therapy, then you need to make sure you change the IV bag when empty and take extra precautions to minimize risk of accidental catheter removal. When dealing with IVs, you should always make sure you're looking for any signs and symptoms such as chills, fever, headache, backache, nausea, vomiting, shortness of breath, cyanosis, and shock-like states. Venous spasms are caused by irritating or chilled fluids or sometimes due to rapid flow rate, which causes a reflex action where the vein goes into a spasm near the intravenous infusion site. Treating a venous spasm, you decrease the infusion rate, apply warm compress if the solution is cold, and can resite the cannula. Phlebitis is inflammation of the vein that may be caused by the initial decrease in flow rate due to spasm or the presence of the needle in the vein. You can remove the cannula, apply warm moist compress to the area, and assess the severity of the condition and notify the physician. Infiltration is when fluid accumulates causing the tissue to swell, which makes the affected area puffy. The skin appears white in color and may feel hard and cool to touch. You can remove the cannula, elevate the limb, and use warm or cool compress for comfort. Catheter embolism occurs when a portion of a plastic cannula breaks off and flows into the vascular system. If this happens, you can apply a tourniquet proximal to the site. Use supportive therapy if required, and prepare for fluoroscopy to locate and remove the fragment. Pulmonary embolism is obstruction of the pulmonary artery by a clot arising in the peripheral veins. The treatment is to use oxygen, position patient in semi-Fowlers, and notify physician. Air embolism is a condition where a given amount of air inadvertently enters the vascular system, reaches the heart, and produces cardiac arrest. It is important to prevent further infusion of air, turn client to the left side, monitor vital signs, and notify the physician. Aging causes changes to the skin, vein walls, and circulation, which can lead to complications if not protected properly. They often experience weakened immune systems, so it is vital to maintain aseptic technique to avoid infection. Being too vigorous can cause friction on their skin that can damage surface tissue, so it is important to be as gentle as possible and keep areas dry. Skin becomes paper thin in the elderly, so you can secure the catheter with hypoallergenic tape or cover with an IV transparent dressing. Use smallest catheters possible and insert the catheter directly on top of the stabilized vein. Immobilize the catheter well to prevent movement, which may cause skin tears. Also, stabilize the vein well, as veins in the elderly have a tendency to roll upon insertion. Fragile veins may cause infiltration immediately upon catheter insertion. If the vein is palpable and visible, consider starting the IV without a tourniquet or apply it very lightly.